I hope my screen is visible.
Yes.
Dr. Archana Baser ma'am is here, Amogh.
Yeah.
Yes. Hi ma'am, good evening.
Neharika, good evening.
Good evening, ma'am. How are you?
I'm good. I'm good. Just driving back home after the work, so I thought this is the transit times.
Amogh, we can start now.
Okay, ma'am.
Yes.
Good evening, everyone.
Good evening.
Welcome you all on behalf of FOGSI Young Talent Promotion Committee on this webinar on male infertility and adjuvants. So, what better day to talk about male infertility than on the International World Men's Day? Today is something that is very rare to see, acknowledging the men and understanding them and trying to help them to achieve the parenthood that they desire. So male infertility accounts for around 40% of infertility, which is generally ignored. What we see in our OPD are some typical stereotypical type of male patients who have this response. मुझ में प्रॉब्लम नहीं, मेरे बीवी में ही प्रॉब्लम होगा. मुझ में कमी तो हो ही नहीं सकती है. टाइप 2. टाइप 3, हाँ शायद प्रॉब्लम हो सकता है. टाइप 4, यार शायद इनफर्टिलिटी के लिए मैं ही जिम्मेदार हूं. एंड टाइप 5, सर मुझ में प्रॉब्लम है, डोनर यूज कर लो, मेरे वाइफ को मत बताना. So taking into account all these different types of stereotypical patients, what we should do is investigate the male, and the male in infertility practice, especially in rural areas, are neglected and not diagnosed or investigated as the cause of infertility in the couple. So with this, I would like to invite all the dignitaries for the traditional lamp lighting ceremony. With this, I would like to invite our today's chief guest, Dr. Jaydeep Tangsar, Honorary Secretary of FOGSI. Sir is a Secretary General of FOGSI. He is a immediate past president of MOGS, Chair of International Federation of Obstetrics and Gynecology Committee for Safe Abortion, Deputy Secretary Asia Oceanic Federation of OBGY. He was awarded the FRCOG Honoris Causa in 2020 by the RCOG. Sir is a chair of MTP Committee FOGSI from 2004 to 2009, Vice President, Forum for Enhancement of Quality in Healthcare. He is a consultant at Ashwini Maternity and Surgical Hospital, Center for Endoscopy and IVF, co-founder of Esperanza Healthcare Private Limited, Program Director and member of Board of ProFert IVF. And he is a visiting consultant IVF specialist at more than 15 IVF centers. He has been instrumental in drafting the proposal for FIGO, which has resulted in billions of dollars of grant in a 10-country project. He is currently working on developing a proposal for 6-country project on menstrual hygiene in Asian countries for the AOFOG. Sir, your you are already well known and you actually don't require a lot of introduction, but this was a short presentation that we could accumulate for you. With this, I would like to invite you for your words of wisdom for today's webinar.
Thank you, Amogh. And I must thank Neharika, who is the dynamic chair of the Young Talent Promotion Committee, one of my favorite committees led by one of my favorite persons. So it is indeed an honor and a pleasure to be here. Thank you for inviting me, Neharika. I must acknowledge the fact that this is a very relevant topic. I think, Amogh, you spoke about the various types of patients who come with male infertility, and I would actually think that this would be a good idea to raise awareness about male infertility. It seems to be quite a taboo topic, something which is not discussed, and it's rather unfortunate that with the kind of patriarchal culture and society we live in, the entire burden of fertility is vested with the woman rather than it being the shared responsibility of the couple. So webinars like this are most welcome, if not only to advance the science of male infertility, but also to raise awareness of male infertility as a problem, not only within the community at large, but within our specialty particularly. So I must acknowledge the dynamism of our president, Dr. Alpesh Gandhi, the vice president in charge of the committee, Dr. Archana Baser. I see that you got a fantastic program lined up, great topics with fantastic faculties. You have Keshav, who's going to be speaking and is also going to be part of a panel. And then, of course, you have some of the icons of IVF in the panel. There is Dr. Jatin Shah, Dr. Ameet Patki, there is Kundan, Amogh, Ashwini, Dr. Sunil Jindal, and the panel is going to be also having Dr. Priya Selvaraj, Mr. Ramesh Patodia, and Dr. Sunil Jindal. It's going to be moderated by Parasuram and Amey, the future stars, and in one instance already a star of FOGSI. So I'm looking forward to the panel. I'm looking forward to the webinar. Neharika, all the best, and may you achieve greater and greater heights, not only in FOGSI, but outside FOGSI also. Thank you again for having me, and I wish you all the best for this webinar.
Thank you so much, sir.
Thank you so much, sir. Now moving on, let us begin with the first talk. And for that, I would like to invite our chairpersons, Dr. Sunil Jindal sir and Dr. Archana Baser ma'am. Dr. Archana Baser ma'am is a consultant OBGY and director at Akash Hospital. She is the organizing secretary of AICOG 2021, vice president FOGSI 2020, fellow representative of AICC RCOG West Zone, imaging science committee chair at CEFOG. She holds the Guinness World Record for removing the largest uterine tumor. She was the chairperson of FOGSI Imaging Committee from 2015 to 17, organizing secretary ISAR 2016, and managing committee member to ISAR 2018 to 20, IAG 2018 to 19, and ICOG 2017 to 19. We welcome you, ma'am. I would like to welcome Dr. Sunil Jindal, sir. He is a chief consultant laparoscopic surgeon and andrologist and reproductive medicine specialist of Jindal Hospital. Scientific director, Dr. Madhu Jindal Memorial Test Tube Baby Center, Meerut. Vice chairperson, Delhi ISAR, Delhi IAG. He has many publications and presentations presented at various national and international conferences, and he is gold medal for best postgraduate at MAMC, New Delhi, and over 80 awards. Over 80 awards from different organizations. We welcome you, sir. And I hand over the mic to the chairpersons. Thank you.
Thank you, Amogh. Hello.
Ma'am, you're audible.
Yeah. Thank you, Amogh. And I think it's my proud privilege to be here on this program. And you really enlightened me by this, that today is the Men's Day. So, and to keep the this webinar of on the Men's Day, it really makes it really good. And I'm ever indebted to my dear Neharika for doing such great activities on infertility and all the subject and she has taken Young Talent Promotion Committee to a greater heights. So all the best, Neharika, and congratulations for doing this program. And I really want to tell all of you, those who are here attending the program, to participate in the next upcoming program of FOGSI, that is Say No to Violence Against Women and Girls. And I hope and I wish all the best for this webinar, because it is going to be great with so many good faculties here. I mean, we have a speaker, the young budding speaker, Keshav Malhotra, and the panelists are just the stalwarts of the panel. So I'm really looking forward for a great day today. So over to you, Dr. Jindal, to introduce Dr. Keshav Malhotra.
It's such a pleasure today to introduce who else but Keshav, you know, and it's interesting because I had never imagined that the chairman of the committee could be somebody as bright and talented as Dr. Neharika, who always is there smiling. So fantastic on Men's Day to have this program by Dr. Keshav on micronutrients would be great. And Dr. Keshav, of course, holds a degree in clinical embryology and is one of the first people to receive the ISHRI certification in the country. Apart from that, he's the lab director of Rainbow IVF and now is the director of Malhotra Embryology Training Academy. Keshav, I get such fantastic mails and so many people I have known who got trained by you. It's amazing. To become such a good trainer at such a young age is fantastic. And he's on the board of ISAR and ISPAT and has worked on key projects pertaining to embryology in the country. And of course, he received the Budding Embryologist Award 2019 from Economic Times. Dr. Keshav, the stage is yours, and I would really like to listen to you on micronutrients.
Thank you so much, Dr. Jindal, for that very kind introduction. Thank you to Neharika for inviting me for presenting here in front of such an amazing array of speakers and distinguished guests. It's absolutely an honor speaking in front of all of you. Also, Dr. Archana ma'am for chairing this session. Today's topic is going to be on micronutrients in male fertility, and I'm going to try and keep it a little short because we have a lot of the same things which will be covered in the panel. So I really don't want that much of an overlap to happen. Obviously, it is International Men's Day, and what better day than today to actually create awareness on this very important topic, that's the neglected male in the IVF unit. And this is something that we're all going to discuss throughout this session today. So like you all would know, in the last 70 odd years, there has been a 20% drop in sperm volume, and there's been almost a 60% decline in the sperm production. So the number as well as the volume of the sample is going down. If you look at the morphology of the sample, that also, if I talk about like, let's say 1960s, the normal morphology at that time was around 40%. And now if I talk about today, the normal morphology is around 4%. So we're seeing a very sharp decline in numbers, a very sharp decline in the parameters which are considered as normal. And this does tell us a little bit about that male fertility is on the decline. Now, if I look at the last 60 odd years, and if I look at the changes that have happened over these last 60 odd years, I think the most important change that has happened is with our environment and with the kind of diets that are now being had, the kind of stress levels that are there, etc., etc. So this is one of the most important contributory factor, according to me, as far as the parameters are concerned. So this is a very nice meta-analysis which I could find. And this was almost about 2000 articles where they actually found that men who are having diets which were rich in certain nutrients like omega-3 fatty acids, vitamin E, vitamin C, selenium, zinc, lycopene, etc. These men had a higher or a better fecundity as compared to men who were actually not having a very enriched diet. And this also tells us that probably this diet or the nutrients that the man receives does play a role in the fertility potential of that person. Another concept that has emerged in the last decade or so is sperm DNA. Now we know that we need an integrated sperm DNA in order to achieve a healthy live birth. Because like whenever an embryo is being formed, the genetic component comes from the female as well as the male partner. And if the male partner's genetic if the DNA is compromised, then definitely we are not going to actually have a healthy or a viable pregnancy. Let's go through a little bit of literature regarding the same and regarding sperm DNA damage. We know that there are a lot of causes for sperm DNA damage, and it can range from pathological causes like varicoceles to more iatrogenic causes or inflicted causes like smoking, stress levels, alcohol consumption, infrequent ejaculation, increased BMI or a poor diet, aging. Then there could be infections. It could be because of cancers, pollution, toxins, a high level of caffeine intake. There are so many causes that can actually affect the DNA of the sperm. And when we talk about how this DNA actually affects the fertility, there are a lot of meta-analysis, especially the recent ones which have come post 2016, which have actually linked sperm DNA to live birth or viable pregnancies. Now, if I look at sperm DNA damage and its effect on early post-implantation, there is a definitive role of sperm DNA damage in early losses or early miscarriages. So women who are actually having early miscarriages, it could be potentially because of an improper sperm or an improper paternal genome getting into the embryo. Again, sperm DNA also affects the quality of embryo post ICSI. So even during that 5-day development process that we embryologists can visualize in the laboratory, we do get to note that these embryos could have a higher fragmentation rate, could have a higher degree of embryonic arrest, especially before the 8-cell stage, because that's where the embryonic genome gets activated. So if you're seeing these signs, then maybe in the next cycle, I would want to actually advise that per patient to undergo a DNA fragmentation test. As far as IUI outcomes are concerned, it was found that couples who had undergone IUI and the male partner had an DFI of less than 30%, they had the same statistical probability of achieving a pregnancy as a normal couple would. But once that DNA fragmentation index went above 30%, the chances of getting quite dropped. Now, why is this sperm DNA damage happening? Now, most of it can be linked to oxidative stress and the imbalance between the production of antioxidants within the body. Now, we have to understand that a certain amount of oxidative stress is important, because this oxidative stress in the earlier stages of spermatogenesis helps in chromatin compaction. It also helps to regulate the number of germ cells by an induction of apoptosis during the spermatogenesis process itself. Also, in the mature stage, or when the sperm is mature, ROS to a certain extent will help in induction of capacitation, will help in induction of acrosomal reaction, will also contribute towards mitochondrial stability and sperm motility. So it is important. And why am I showing this slide here is because it's very common practice from clinicians that they will prescribe antioxidants left, right, and center to any person or any man who's walking into the clinic. And what those antioxidants do is reduce the ROS, which is being produced in the body. And when it goes lower than the normal limits, it can actually be detrimental. So a good point of advice here would be to not prescribe antioxidants empirically to every patient who walks into the clinic. ROS also acts as a defense mechanism when the leukocytes actually utilize them. And this also helps us in countering infections and inflammations. But when the ROS levels increases, that is where the detrimental value comes into play, because now this ROS is going to damage the DNA, it's going to damage the proteins, it's going to damage the lipids, the membrane is going to lose its stability, DNA will start leaking out. There's so many things that would happen. And what happens is that this ROS will kill one sperm, that sperm is going to produce, or that dead sperm is going to produce more ROS, and it becomes a vicious cycle. And that is why, again, in such patients, the role of antioxidants or micronutrients is beneficial. Now, there would be a very common question that would arise here is that, and that would be that even with impaired DNA, there are a lot of patients who do conceive naturally. Now, here is the oocyte's repair capacity which actually comes into play, because we have to understand that the oocyte does have a certain amount of capability to repair that damaged DNA. But now once the age advances, once the oocyte quality is also on a decline, it will be those patients who will actually suffer the most. And that is why if you're actually getting people who are above 35, where the woman is above 35, in those patients, I would really advise that we test for all of these factors beforehand, because already their reserve is going to be compromised. The number of embryos that you're going to get is going to be compromised. So might as well do all of these tests beforehand in order to get the best embryo out of that patient. Now, most of the medicine that arises here, or most of these micronutrients that we are going to talk about in the subsequent slides, have a direct association with the sperm mitochondria. Now we have to understand that mitochondria is the only energy source for the sperm. It's the only like metabolically active location within the sperm, and most of the components that we're talking about, the ROS, the antioxidants, etc., everything is going to be regulated by the mitochondria. There's this beautiful paper which I came across, and they actually, so they took a sperm sample, they visualized it under electron microscope. So this is how a normal sperm looks like under electron microscope, and you can actually see the number of mitochondria which are present in the sample. You can also look at the shape and the size of the mitochondria which is present here. Now then what they did was they subjected this sample to ROS, and then they try to visualize the change in the mitochondria, and you can actually see that the number of mitochondria reduced, and also the size of the mitochondria was hampered. It was swelling up, and obviously these are degenerative changes which are happening within the mitochondria. So that led us to believe that most of these ROS acts upon the mitochondria, and to counter this, we have to actually improve the mitochondrial content within the sperm. And that's where all of these micronutrients actually came into play. So just to name a few, we have coenzyme Q10, we have L-carnitine, we have lycopene, beta-carotene, vitamin C, vitamin E, methylcobalamin, you have astaxanthin, and you have lipoic acid. These are some of the common antioxidants which are present, and their role in male infertility management can be actually summarized in this table right here. I'm also going to talk about them in detail. So let's start with coenzyme Q10. Now this particular molecule is responsible for almost 95% of the human body's energy, and it's basically a component of the electron transport chain within our cells. Right. So CoQ10 is not just going to act upon the mitochondria of the sperm, it's actually going to act upon each and every cell within the body, and it's going to try and increase the energy of that particular cell. And again, in other forms like ubiquinol, etc., CoQ10 is actually more beneficial as far as male fertility is concerned. So just a few papers which I would like to bring to your notice. So this is basically the amount of CoQ10 present in normal samples and in pathological samples. So it was found that CoQ10 was significantly reduced in men who had like varicocele, men who had higher DNA fragmentation, etc. So this sort of brings us to a correlation between CoQ10 and sperm DNA fragmentation. Then the supplementation of CoQ10 as an antioxidant, and this is an RCT, which actually had 60 infertile men with idiopathic oligohistanozoospermia who received almost 200 milligrams per day of CoQ10 for 3 months. And it was seen that there was a significant positive correlation between the CoQ10 concentration and the normal sperm morphology, which happened post this supplementation. And even a 3-month supplementation did show slight benefit. Now, ideally, it's recommended that you supplement any antioxidant for 2 cycles of spermatogenesis, which corresponds to about 6 months of antioxidant therapy. Now, looking at certain other complements of CoQ10, you can see that quinone and ubiquinol, these are two components, and both have actually shown to be quite effective in managing male subfertility issues. Again, another study where 287 infertile men with idiopathic oats was treated with CoQ10. Now, this time it was 300 milligrams orally twice daily for 12 months. And they actually showed an increase in sperm progressive motility, increase in morphology. And this was significant after 12 months of therapy. And almost 34% of them actually had spontaneous conception over a period of 24 months. Again, a similar study. Now, obviously, by now you must already have been appraised of the benefits of CoQ10. So let's move on to the next antioxidant, and that's L-carnitine. Now, this is a comparison of the effects of varicocelectomy with oral L-carnitine supplementation. So the subgroups that were there was men who underwent a varicocelectomy, and in the other group, it was men who had varicocele but were given L-carnitine supplementation. And it was found that L-carnitine was as effective as a varicocelectomy in improving the sperm parameters, especially if it was a lower grade varicocele or a varicocele less than grade 2. L-carnitine also has multifold benefits. Again, most of the times it's acting inside the epididymis, which is where the sperms are going to be stored and which is where ROS is most damaging. So that's a very, very important factor which plays in favor of L-carnitine. It also has anti-apoptotic effects on the sperm. It has positive effects on sperm function and also works on erectile function as well. Again, this is the same study where it proved to be beneficial against varicocele. Now, astaxanthin is another very new antioxidant. It's gaining a lot of significance in fertility practices because it's one of the most potent antioxidants which is available in the world at the moment. And again, it's a naturally derived antioxidant, and it is almost 10 times more active than zeaxanthin and almost 100 times more active than alpha tocopherol. So it's a very potent antioxidant, but then it's also a little a bit on the expensive side. And that's one of the reasons why it might not be like the patients might not comply to it, especially because they need at least 6 months of therapy with astaxanthin. But this is a study where they actually studied different concentrations of astaxanthin in seminal plasma and its role on capacitation, hyperactivation, etc. And it was found that at about 20 international units of astaxanthin within the seminal plasma, it was giving the most beneficial effects. Lycopene is another very commonly used antioxidant. It's commonly available in a lot of fruits and vegetables as well. And it's again one free radical which actually causes a beneficial effect on motility, viability, and also apoptosis. So it's got, again, multifold benefits as far as its efficacy is concerned. And there are a lot of studies which have studied the effects of lycopene on parameters like sperm concentration, motility, morphology, and viability, and have reported benefits. I'm going to come to the Cochrane review last, and I'm going to end with that. But these are all the reviews that are there in literature. Coming to another very versatile component, and this is zinc. And this is probably one of my favorites to actually supplement, because it's not just going to affect the sperm quality, it's also contributing to very, very important factors like it's a very important part of the seminal plasma. It helps in liquefaction. So if you have a person who comes into the clinic where you have a very highly viscous sample, it's not dissolving or liquefying as such, then give a zinc supplementation for about 3 months and see the difference that it makes, if obviously the patient has time. This zinc also stabilizes the cell membrane, so it makes the integrity of the sperm membrane better, so they're not going to die soon. So men who actually suffer from sperm survival issues, where the sperm survival is not great, in those cases, zinc is a supplement that should be added. And again, it also has antibacterial activities and also protects the chromosomes as well. So it's again a very, very versatile supplement. Now, coming to the latest Cochrane review on antioxidants. Now, if you would have looked at the previous Cochrane reviews, they've all shown that antioxidants are actually not beneficial and they are the same as placebo. But this is the latest one, which was published in March 2019, where they compared oral antioxidants compared to placebo or no treatment. And they actually found that it's associated with an increased live birth rate and an increased clinical pregnancy rate. And again, this is something which is again coming back into significance. So earlier on, where people were just going against antioxidants, is now coming back into the picture. Now, a little bit about a study that we did at Rainbow. These are all preliminary results, but this basically focuses on ubiquinol and resveratrol. Now, ubiquinol is an electron-rich form of CoQ10, like I mentioned earlier. And CoQ10 is obviously a component which your body is making and using daily, and it's all the cells that are making it. It's got a higher antioxidant activity and it's got superior bioavailability. So here, the benefit of using ubiquinol is that lower doses might actually give you the same results with a higher dose of CoQ10. And why we actually underwent, why we did this trial was for the reason that the success of ubiquinol is still not demonstrated worldwide. Now, the next component that we supplemented was resveratrol. And this is a stilbenoid. It's a natural phenol. It's produced by several plants in response to an injury, and again has anti or like beneficial effects as far as an injury is concerned. It has been identified to actually have anti-aging effects as well, and it may have a therapeutic or protective effect against certain abnormalities in semen, which again, there are very few studies which have said this. So this was one of the reasons why we chose this component to do this study. We designed an RCT where we had all patients who had OATs on at least 2 semen analysis samples being recruited for this study. Participants were actually excluded if they had a history of like cancer or if they've underwent chemotherapy, had cryptorchidism, varicocele, genital tract surgeries, had abnormal karyotypes or abnormal BMIs, etc., etc. So the reason why we wanted to exclude this was because we didn't want any confounding factors as far as the efficacy of these 2 components was concerned. Now, we're reaching about 100, a number of 100 in both the wings or both the groups that we studied. And when I look at the pre-sperm counts, it was to the range of about 10.5 million. And post-therapy, and this is post 3 months after therapy, it came up to about 12 to 12.5 million. Again, this is not a very significant jump, but it is just showing us a trend in increasing the sperm count numbers. In the control group, which actually received no treatment, there was absolutely no difference. We saw a significant jump in the sperm motility post-therapy. And from, let's say, about 33%, it actually jumped to around 46.5%. Again, in the control group, there was no significant change in the motility. And surprisingly, we also saw a beneficial effect on the morphology as well, because I was always of the idea that sperm morphology would not change regardless of any kind of therapy that we give. But using these components, we have seen a significant increase in the sperm morphology as well. So just to end, it's already been mentioned in literature that there are a lot of causes of oligosteatoteratozoospermium. Most of them actually pertain to lipid peroxidation because of those ROS, which I talked about earlier. There's also a reduction in hyperactivation, motility, etc., because of the presence of ROS. And again, there is a direct damage which ROS does on sperm DNA, which can also cause all of these factors. And these 2 components that we studied have shown that they partially reduce apoptosis, they revert sperm motility, they also improve mitochondrial activity. And again, certain features like morphology, etc., was also something that might improve with this. So with this in mind, thank you so much for inviting me for this wonderful session today. I hope this was beneficial. And I'll be happy to take in questions either right now or post the panel whenever they are scheduled for. So thank you so much.
Thank you, Keshav. It was an excellent presentation. I think you have made look this very difficult topic of OAS very, very simple. I mean, it was a beautiful lecture with all the current updates. And if I have to just summarize in 1 or 2 words, I think you have made it very clear that do not use antioxidants injudiciously. Just has to have a right indication and identify who needs it. So don't do the bombarding of antioxidants to all men who are coming with oligospermia. And another thing is, like you have mentioned about the DNA fragmentation test, I think that's also very, very important. So I think it was a good lecture with all the information needed on the subject. Well done, Keshav. Congratulations and all the best for the future. Dr. Jindal, if you want to have
Yeah,
any
yeah.
comments.
Thank you very much, Dr. Archana. In fact, two things which you pointed out is that everybody does not need antioxidants. And the second most important thing is if they need it in the correct dosage. Unfortunately, what is happening is most of the drugs and most of the medicines which are at the moment in the market, they are not able to give the correct dose, whether it's for the male or whether it is for PCOS for that matter. So I think these are two things which you have brought out, which are fantastic. Great job done.
Thank you
Very
so much.
nice, Keshav.
Thank you.
Do we need to take questions now, or we do it after the panel with Keshav?
Ma'am, we have one question. Let's take it now. Keshav, Dr. Nija is asking that in a couple with a history of 2 early abortions planning IVF, DFI was 32%. After treatment with antioxidants for 90 days, DFI increased to 41%. What
Yeah.
could be the possible reasons, and how do we go about it now?
So thank you, Dr. Nija, for that question. Now, this is a person who's already had 2 early abortions where, like I mentioned, there could be a pathogenic cause behind it. And like the history mentions, the DFI was increased. Now, first thing that I would want to mention here is that whenever we're doing a sperm DNA fragmentation test, it could be variable. Lab to lab reports might vary. Even within the lab itself, it might vary. So that's something that you have to consider. Second thing is the patient compliance, whether the patient is taking antioxidants continuously or not. That's something that you have to talk to the patient about. Third thing is whether the right antioxidants are being prescribed to that patient. That's also something that we need to worry about, because let's say if you've just given zinc as a supplement, or you've given a huge cocktail of antioxidants, they might not really work, like Dr. Jindal mentioned earlier on right now. They might not be really working on it. Also, one other thing that I would want to actually bring to notice here is that in such a case where you're seeing that the DFI is increasing, please try and find the cause of this increase in DFI. This might be a patient who might have a varicocele. So getting an scrotal ultrasound might be beneficial in such a patient. This might be a patient who might be under a lot of stress, might be working in a very stressful environment or a high heat environment, might not have changed those factors. So there are so many causes that need to be considered, and probably if you discuss with your patient, you'll probably come to pinpoint at least 1 or 2 of them.
I think there was one more question about the vitamin C, role of vitamin C and steroids. So
yeah, so vitamin C and vitamin E are also 2 very, very good antioxidants in a patient who's non-affording. If it's a patient who comes to you where you can't prescribe a good, nice cocktail of antioxidants which works, in such a patient, giving these 3 components, vitamin C, vitamin E, and zinc, and I think Dr. Jindal would agree with me here, these 3 work wonders. So for such patients where cost might be an issue, please try and use these supplements instead.
And I have one question, Keshav. Do you recommend doing this fragmentation, DNA fragmentation in all the male with oligospermia, or do you identify certain groups? Because again, the cost becomes a little factor here.
So we don't really do it in all the men who have OATs. If they show a certain history of like DNA damage and how it's affecting, like if a couple walks into your clinic with miscarriages, then this is a test that I would advise to those patients. If it's a couple who's had repeated IVF tries and they've not come to a complete diagnosis of why it's failing, then I would advise a sperm DNA fragmentation test. If it's a couple where embryos are arresting early or the blastulation rate is not good, then I would probably tell them that this might be a probable cause. Again, embryonic fragmentation, I would really want the patient to undergo a sperm DFI. Age above 40. If it's a man above 40, I would tell all of them to actually undergo sperm DFI. So these are certain indicated areas where a sperm DNA fragmentation test could be done.
Thank you so much. I think that was again a very important point. Whom you are really, you have to say that no, you have to get it done. And there are some where you can say, okay, well, we can see later. Thank you very much for a good session, Keshav, Neharika, Dr. Jindal. Thank you very much. I think the next team is waiting and we are looking forward to a good panel discussion. Thank you.
Thank you so much, ma'am. Let's move on to the next session, that is the panel discussion. It being the International Men's Day, let us talk about the neglected male. To start, I would like to invite the moderators for the panel discussion, Dr. Parasuram and Dr. Amey Purandare. Dr. Parasuram is the Medical Director of CMAR Coaching, Scientific Director of CMAR Fertility Centers Kochi in Coimbatore, and he is a visiting consultant at Paul's Hospital. He has won various awards, including the Manish Banker Young Achiever Award, Champion of ISAR Award, and has been invited as a speaker at several national and international conferences. Welcome, Dr. Pasu. Dr. Amey Purandare, sir, he is a consultant and gynecologist and a fellow in gynae endoscopy surgery. He is a consultant at Purandare Hospital, KJ Somaiya Hospital, Reliance Hospitals, and Bhatia Hospital. He was a Joint Secretary of FOGSI 2019, Chairperson Food, Drugs, Medical, Surgical Equipment Committee of FOGSI 2015 to 2017, Assistant Administrator FOGSI Manyata Project on Quality Care in Safe Childbirth, Member Managing Committee in Metta Youth Council MOGS. He was the Honorary Secretary Amogh 2014 and 15 and Zonal Coordinator in 2015 and 19. Welcome, Dr. Purandare, sir. And now I hand over the stage to Dr. Parsu and Dr. Purandare, sir.
Can you let me share the screen? Can you just make me the host, co-host?
Thank you, Amogh, on behalf of Parsu and myself for those kind words about us neglected males. Okay. First of all, I'd like to thank Neharika for considering us for this very important panel. I know the whole focus is on Neharika because she's the chairperson of the Young Talent Committee. And just like we have the focus on Deepika and Anushka in Bollywood, because I'm from Mumbai, okay, the focus is always on the female, whether it is a gynecologist or whether it is the mass population. And to have two males moderate this panel on the neglected male, I think Neharika, on Men's Day, I think the coincidence seems to be well appreciated. So thank you. And we all know, and Keshav did make this point, that it just takes one sperm to fertilize one egg. And nature has given man millions of sperms. So is this an luxury? Is this an essentiality? Is this an overdose? Because you know overdose can cause its own problems, okay, be it with alcohol or be it with any other things. So is this a rule of nature, or what's nature's idea behind all this? I'm going to leave it to the panelists to tell us more on why the male is often neglected and how male infertility contributes to infertility in general, and how we can help in achieving the best results if there is a male factor of infertility. Over to Parsu to introduce the eminent panelists.
Thank you, Amey. I think it is kind of a big honor to kind of moderate this session with so many stalwarts, and sincere thanks to Neharika to make sure that she got all these very senior and very experienced people to come over board and kind of share their whole idea. I'll be very quick. I think all of them are known to each one of you. There is not need of a formal introduction, but still, for the sake of the whole thing, Ameet Patki, I think all of you know him being the Medical Director of Fertility Associates Mumbai. He's the Vice President ISAR. You've known him always for a very clear presentation, the way he explains things. I think all of us are aware of Dr. Amogh Chimote, the medical director at Vanchtara Fertility Center, Nagpur, the young dynamic laparoscopic surgeon who's been now he's one of the organizers of this particular meeting. Then Dr. Ashwini, who's also the IVF consultant and chief embryologist at Asha Kiran, the general secretary of FOGSI. We've known her as being a very efficient organizer and has been a fulcrum in a lot of the conferences that happen in Mumbai and Pune. And the ever charming Dr. Jatin Shah, we've seen him for so many years. I was calculating over 30 years of experience, and the celebrity doctor. But I think what all goes behind is the amount of hard work that he does, and how much efficiency and the results that everybody envy that he comes out with. And then we have Dr. Kundan Ingale, my very close friend, again, who's holding the very prestigious post of the chairperson of the FOGSI Infertility Committee at this point of time. Several awards to his credit, have presented international papers. Then we have the very beautiful Priya Selvaraj. I would not say that she's having an experience of more than 20 years. You might know her age, but she doesn't look that way. But again, welcome her. She's the scientific and clinical director at GG Hospital with many publications and articles to her credit. And then again, the very ever charming Dr. Sunil Jindal, the most sought after male infertility speaker in India, I think, after the seniors and Dr. Rupin Shah. And I think one thing that I envy him more for is his voice, his shairi, and his songs. And again, the young and dynamic Keshav Malhotra, as being the lab director of Rainbow IVF, he had already got an introduction. Then also like to include one of the panelists is Mr. Ramesh Patodia, who is the CEO of Ambrosia Nutrition, who's been the organizer for this event. He's a chemical engineer from IIT Mumbai and management course at IIM Calcutta. He started this Ambrosia Nutrition, which focuses on natural products, where we do not have any definitive treatment in allopathy. And yes, as the icing or the cherry on the top, we have Dr. Malhotra, again, the managing director at Rainbow Healthcare and director of Rainbow IVF. Many credentials to him. So I don't think there's any way that I can introduce him in this August gathering. So with saying all that, I think the first question I will kind of shoot up to him itself, being one of the senior most male infertility specialist gynecologist in India. One question that I always had in mind is, why are males neglected? Is it because majority of these infertility are seen by gynecologists? We really don't know how to examine a male, or is it because majority of the gynecologists being females, are we too shy to examine a male? Why do you think males are neglected?
So thank you very much. Thank you. I'm on a highway, so I might be having a bad connection and interruptions. But yes, a very happy Men's Day to all the men on the panel and all the men who are listening to this. Well, men are definitely neglected, especially when it comes to infertility. There are many factors on this. The first factor is the social factor. Men believe they are like all powerful and nothing can go wrong with them. If they're about to, if they can have sex, that's it. They can have babies. So that mindset is, or never go to the clinic till they're actually called for it and till their wife actually tests all normal. So men are expected to produce children immediately after marriage. That was the thought. Even these days, there are a lot of people want very early children still. And if these men don't come to the clinic because they think everything is right with them, that is one cause of neglect. Then, of course, yes, you brought up the point of female gynecologists, but remember, the American Society of Reproductive Medicine, ASRM, who was a female, and she's a gynecologist, and she's an andrologist. So it's not that when men can examine women, why can't women examine men? It's that's again a mindset of the gynecologist also. So if they cannot examine, then make someone at least see the testicular size, measure. You have the testicular sizes, balls and volume. You can do that. Just take a drop of semen sample and look under the microscope yourself. That's what is needed. So it's awareness and the mindset which needs to be changed. And then men will get more attention. And because it's 50%. So 50% you cannot neglect them at all.
Thank you, sir. Thank you. So I'll go to the first question to start with.
Parasuram, can I just add one?
Yeah, please, sir.
Yeah.
Please.
Again, thank you, Neharika, so much. This is a really, really important topic. And I'm really grateful. Of course, she's my very dear. We've almost been together for 28 years, 25 years now. I have a different clinical take on, why this negligence of the male is happening, and which is why I just wanted to butt in. Actually, if you ask me, and it may be a shocking answer, I think the men are being neglected because of the advent of ICSI. 20 years ago, before ICSI came, we used to actually spend time on the male. We used to take a history, ask them about smoking, drinking, check for varicocele, send them to Rupin Shah for maybe a surgery, then think of IUI, then IVF, and then donor sperm. When ICSI came, we got this concept that all you need is one sperm. So we just started neglecting, okay, the sperm is there, the semen is okay. For ICSI, you go for ICSI, you'll conceive. It's only when we started having all these ICSI failures, when we started getting into DNA fragmentations, then the concept of MOSI, male oxidative stress infertility and all this, that again focus is now shifting back to actually treating correctable causes in the male. So this is a slightly different take where I feel over 20 years, as ART people, we started neglecting the male because we said, okay, low sperm count, do ICSI, and that's the end of the day. But I think that needs a rethink, and that's why today's panel is very, very important for us.
No, but I agree partially with Jatin, but definitely yes, a history is always taken, and it is the examination which is neglected, and it's an examination, and then suddenly you say no sperms, take him up for TISA, ICSI, exactly. And on the table when you're about to do a TISA, you find the testes are hardly there, so nobody is actually bothered to see the testis size, and then you're taken him on the table to do a testicular biopsy. So now that is the way. That is the neglect part. So that clinical part was neglected. Yes, because we'll do ICSI, we'll do TISA. If it is zero sperm, call him over. We'll do and freeze the sperm and just do a hormone, advise a hormone without even touching them. So that part, the touch part is missing.
Can I also butt in? I'm sorry. Pursue.
Yes, youngest male, please. You have the privilege.
So one more neglect I think that exists is the psychological neglect which happens for all of these men who are suffering from male infertility, male subfertility, etc., etc. And that's one place where I think each person is just said, okay, you have to just man up, blah, blah, blah. All of those common stereotypes come into play here. And the kind of detrimental aspect psychologically that could occur on a male if he's suffering from infertility, that's something that's not considered. So that's also one more important point that we should really think about.
All right.
On Men's Day, I will say just one thing. Men are very touchy creatures. These men, when they enter and they come to know they don't have sperms, they feel the world has come down. My wife should not know this. And the mother of the man, the first thing she says is, there's nothing wrong with my boy. He's absolutely fine. So men are very touchy. In fact, if you notice, a woman may undergo an ICSI and she may go through everything, but the man will always ask you, is it going to pain a lot? Will it be bad? I don't want my testes to be touched. So men are very sensitive. So that is another reason where the man himself doesn't want to come so many times. So this is one area which once they are there and we make them comfortable becomes, I think, better for the whole thing.
All right, so I think we'll just, I think there's a lot of topics to cover. So I'm going off the first session, the first slide. To Dr. Priya, can you just tell me what are the basic history that when a person or a couple comes to you for fertility treatment, what are the basic history questions that you'll ask, or when you suspect a male factor infertility?
Thank you, Parasu. A quick thank you to the eminent dignitaries here, and to dear Neharika for having me on this panel. Oh, you've already flashed it. Okay. So I'm going to just stick to the male part of it. So for me, among all this history that you have elaborated here, I think, of course, besides age, it's very important for a childhood history of infections as much as he can recollect. And also childhood history of any kind of surgeries, because our own IVF babies sometimes have hernias and they get operated. So we ask them for that history, any kind of previous surgical history. And of course, personal habits is very important. I concentrate on that. And also any family history of a male factor. And sexual history, of course, very important, frequency. And of course, if he has any erectile dysfunction and ejaculatory dysfunction, just by talking to the male, you can elicit many things. And of course, we have to concentrate these days because we see males as young as 30 years or 28 years who come with diabetes and hypertension, and it's this lot of stress and environmental factors that lead to it, and also obesity we see. So basically, these are the main concentrating points that I would elicit from the.
Priya, don't you think of late this has come kind of a circle, sexual problem, because sexual problem is further affecting the fertility, fertility is further affecting the sexual problem. The whole
double income, no sex group. I mean, the ones that are in the, if you look at this ones working in MNCs and these computer engineers and things. So they are the ones who are in our population. They are the ones who are coming with a lot of this sexual dysfunction, as well as they also showed in their semen analysis with oats. So I think it's a vicious cycle. I think it has to do with how we choose to lead our life, and it has a lot to do with our environment and our food and our health and everything.
Okay. Then Ashwini, as far as when you after your history is done, what are the basic system examination that you look for in a male?
Okay. Thank you, Parshu. Thank you, Neharika, for this panel. Actually, you should do a very detailed physical examination. You should look for the size of the testis. Once you've done your CVS and RS, you look for the presence or absence of the secondary sexual characters. You see for the hair growth. You see whether the testes have descended or not, in case they're undescended testes, or if you see any scrotal growth like in hernias, hydrocele, all have to be noticed and make a note of. And I think when the couple comes to you for the very first time, I think if you have a good rapport with the couple, that is a good time to start examining the male partner, to do a detailed physical examination.
Okay. Thank you, Ashwini. And Sunil sir, I think he's on the phone. Okay. Because what to look for as far as a local examination of a male is concerned? What do you think are basic? I think a lot of gynecologists here, what should at least they go and see in a male?
In the male, it's very simple, because for a male, everything is lying outside. So it's very simple for them to examine. In fact, you don't even need an ultrasound for a man. So all that you need to see is, first of all, the position of the urethra, which is important because a lot of people of hypospadias, especially the primary hypospadias, are not able to ejaculate in the vagina, one. Number two, you examine the testes, the size of the testes, the consistency of the testes, the epididymis behind it, whether it is flaccid, whether it is full. And along with that, you examine the cord, which would have the vas as well as the artery and the veins with it. So what happens is that you make a system in your mind where the moment you start examining, you examine the left testes, epididymis, vas, and go on to the cord. Then you go on to the right side with the same thing. And once you have seen all of these, you need a paper to note down with a diagram, which becomes very comfortable mentally for you. So it's a very simple examination.
Just for the audience, do you want to do it standing or lying down?
Okay. Now, the examination can be done lying down, except for the fact that when you examine the cord for a varicocele, you would like the patient to be standing. So the patient feels more comfortable if you make the patient lie down to examine the testes, the epididymis, the cord, the vas. But whenever you have a patient, you examine the varicocele, you always have the patient in a standing position.
And the whole idea of this kind of pulling the foreskin back and just check the amount of
Yes, that is very important, because a lot of people who have phimosis are not able to have proper intercourse. One. Number two, there is a lot of infection which lies in the pre-skin. And this kind of infection, if the phimosis is there, creates a big problem in terms of infection and contamination of the semen. So phimosis should not be there. and this needs to be looked into. And it's a very simple examination. I always say that sonology has been overused. In fact, you hardly need sonology for the male.
We'll come to that. I'm coming to that. All right. So thank you, sir. And yes, Amey.
Okay. So now that the clinical examination and the history has already been discussed in detail, let's start with the common investigations. And my question is to Kundan. Kundan, what would be your checklist of investigations as a gynecologist first, and then as an IVF specialist when you are suspecting or evaluating a male factor of infertility?
So always we will like to start with a basic serological investigation first. In that, I will like to know the blood group, then the complete blood count of the patient, then along with all the serology, that is HIV, hepatitis B and hepatitis C. These are the basic investigation which are needed. And then particular to semen parameters, then semen analysis in detail is must. Now, when I say in detail, it doesn't include a sperm function test in that. A basic semen analysis which gives you an idea about sperm count, sperm motility, different grade motility, and sperm morphology. I think these are the three important pillars of semen analysis where you can, because finally we have isolate a patient who's got absolutely no abnormality, and we want to know a person who's got some parameters which are abnormal. And as it is mentioned in the slide also, if we go into the details, specific investigations, then it comes to like a blood sugar when it is suspecting for a very severe astenospermia, or if you have a known case of diabetes, then you like to know whether it is controlled blood sugar or no. If it is particularly pertaining to the recurrent IVF failure related to the embryo quality, then probably yes, sperm DNA fragmentation index is going to be the specific test which is required to be done. So these are the, I think, common test, and then you have a kind of an individual test which you will apply it in a special scenario.
Okay, so you begin with the basic test and then you move on depending upon what you are suspecting to be the cause or which may be responsible for the male factor. Now, my question goes to Dr. Ameet Patki. We've always been told that the semen analysis has been and will always be the gold standard for male evaluation. But sir, in your practice and in your personal opinion, do you think that there are drawbacks of a solitary semen analysis report?
Thank you very much, and thank you to Neharika for having me. I think the semen analysis still remains as the gold standard. One is because it can be done by people who are trained to do semen analysis. I think from where the report is generated is very important. I think some of the lab people are not trained, and that's why you get reports which are identical to each other without any difference. So reports which are done maybe in fertility clinics or labs which cater to fertility clinics, I think is important, and it still remains the gold standard. I give a lot of importance to morphology also, because you can pick up a large amount of systemic and medical disorders in the men.
Just me, or if everybody is able to hear him?
Can't hear.
There is some disturbance.
I think we are losing out on Dr. Patki there.
To give you a small example, if you have a large number of coil, it is known that in diabetics you can have these are also important. I think it's important.
Okay, so basically what we need.
I just add one small thing here. I think, sir, you did talk about morphology in majority of these scenarios when we actually you do a focus. See, a lot of these IUI centers or whatever semen analysis centers, you go give a semen, you'll get a report in 2 to 3 hours. Do you think a morphology or a detailed analysis can be done in those kind of semen? How reliable are those kind of semen analysis reports?
Keshav, maybe you can put a point of view there.
is not reliable at all, because for morphology, like to be judged, you have to stain the sample and the person has to sit and count 200 sperms and then give a report. Most of these reports which come from pathology say gross morphology 30%, 40%, 60%. I've even seen 80% morphology reports where they said an 80% normal sample is present.
That is majority. Majority is 80%. report.
So and as soon as an embryologist would see that report, they'll completely disregard that, because we know from that point onwards that this was not done correctly. So that's where Ameet sir's point comes really into picture, that it has to be done at a fertility clinic. It has to be done by a lab or a person who has training in semen analysis, and that's very, very important.
Okay. So since we have Amit sir now, first we'll ask him. So you talked about morphology. So there are the three things that we are commonly looking at in assessing a semen report. One is the count, the second is the motility, and the third is the morphology. What is the rule of thumb that a general gynecologist should follow if he looks at such a report? Is there anything that can be simplified? And why is the WHO changed its criteria over a period of time?
I think the WHO was very forward in their thinking. I think normal ranges have to change in lot more things, including vitamin D. Normal is something which is there in 75% of people. So that's what the sperm counts have fallen globally, and that's what prompted WHO to change. There are some fallacies. I don't think we should spend time talking about that, but more important is that the volume should be more than 1.5. The sperm count per ml should be more than 15 ml. The total sperm count should be more than 39 million. And morphology, but the strict Kruger criteria should be more than 4%. I think if you know this much also, it is more than enough. Getting into morphology, head, middle piece, and tail abnormalities, look for acrosome, look for fructose, and I think you will pick up most of the problems. If you find that the volume is less, look for obstructions. If there is large amount of volume, sometimes you have men with 6, 7, 8 ml of volume, look for infections, because that is a place where the large volume comes from, either prostate or seminal vesicles.
Okay. Amogh, one quick question to you. What is the importance of leukocyte count in semen analysis? Is it really relevant?
Yeah, so when you look at leukocyte count, make sure that they're not immature spermatocytes. So if you stain them, you will be able to pick up whether it is actually a WBC or a sperm, and that is important. And if you have a large amount of pus cells, more than 1 million, I think you have to look for some focus of infection.
Okay. Question is Amogh now. Amogh, so if you have an elevated WBC count in semen, do you go ahead with treatment with antibiotics? What is your approach?
Basically, when you just, I think my other. So once you go into you have a high leukocyte count, more than say 1 million per ml. That indicates that there is some kind of infection. That infection you have to confirm, and that is generally seen when you have a change in the morphology, change in the count, change in the motility. So these, along with the leukocyte counts, will tell you that yes, this is actually the raised leukocyte count is because of the infection. Next, what you can do is go in for a semen culture if the leukocyte is more than 2 million per annum. The culture report will tell you whether what antibiotics have to be started. Along with that, if there is change in morphology, there is change in the motility, you can start with the corresponding antioxidants for the same.
Okay. Can we have the next slide, Parsu?
Yeah.
So my next question is to Dr. Jatin Shah. Sir, in your vast experience, what do you see are the common problems, with respect to delayed liquefaction, etc. That how do we troubleshoot these problems? How are they important in management? What do we decipher from them? Parsu, can we have all the the slide?
I thought we'll take one by one.
Okay,
yeah,
fine.
So
delayed
you do see it quite often. If you're in a fertility lab, what we do is we pass the semen repeatedly through a pipette, or we take a 26 gauge needle and an insulin syringe and keep pulling and pushing the semen through and through, and usually it works. If it doesn't, then you can use something like hyaluronidase also to break up the viscosity and the liquefaction.
No, so but basically when the patient comes to you and they show a report with decreased liquefaction or delayed liquefaction, like the patient is also worried. Do you give something? Do you give some what is it, some lytics or some mucolytics and things like that? Is there any
No,
role?
I don't really believe in that. I believe it's better to do a semen wash and do an IUI or whatever. It usually works much better that way.
Clear and simple.
What I'm worried in semen analysis, you know, is a lot of time you can't go by a single report. So many times you get a report of say azoospermia. And just yesterday I had a patient, and the big VIP patient, and the first test showed azoospermia and the whole family panicked. So I said, wait, hold on, before you come to see me, please repeat your semen test in another lab. And as expected, 40 million, 90% motile, everything came normal. So most important take home point is first, always repeat a semen analysis if you get any report of azoospermia, because you have to be sure that it is truly azoospermia, because it's really, really bad news psychologically. Like Keshav said, it can destroy the man's emotions and psyche. So first and foremost, you have to repeat azoospermia. Also, there are say about 5-10% of cases where they are not really azoospermia, but they are something called cryptozoospermia, where you have what we call hidden sperm. Means if you do a thorough search, like an ART clinic would do, we would see say 30, 40, 50 fields, and quite often, surprisingly, you would see a single sperm here and there. So it's very important to also look for cryptozoospermia when you get a report of azoospermia. Of course, then agglutination, we have different types, head to head, tail to tail, and all those. But once again, a good semen wash usually takes care of that. So
Again,
there was in the past,
what
25 years ago, we used to test for antibodies and anti-sperm antibodies and all those things. But right now, ART is really bypassed a lot of these problems like liquefaction, agglutination. Most of these are taken care of by a good sperm wash. Pus cells, of course, we just discussed the WBC count cutoffs, so I don't want to repeat that. Antibiotics only if a culture shows you a positive report. And again, to stress that for all azoospermics also, even on the day of TISA, especially non-obstructive azoospermia, we always take a semen sample in the morning. And a lot of studies have shown that 17 to 20% of these patients will have sperm in their ejaculate on the day of testicular aspiration. So you can save 17%. 17 out of 100 men from going in for an invasive TISA, even if previous reports or previous biopsies, whatever they have shown, it's always advisable to take one ejaculate on the morning of the testicular aspiration. Same also with severe oligoasteno, there are now studies which show that the second sample, you take a consecutive ejaculate, and the second sample often gives you a better count and better motility. So of course, these are more ART oriented things, but since we are discussing semen testing, they become relevant because finally all these are very important in the management of the male.
If I may ask Dr. Jindal, Dr. Sunil, because regarding this culture, because I think that is something which has been, which is kind of asked, it's been kind of a debated everywhere. What kind of antibiotic is it? The culture, semen culture? Do you look at where the infection is arising from? Is it from the tract? Is it from the prostate? Is it from the? How do we know that? What kind of antibiotic we give? If you know that it's from prostatic infection, you know that prostate is a very least what do you say, blood supplied organ. So does it really? How will the antibiotics reach there? What is your preferred type of antibiotic? Can you just add on something there?
Yeah. There are three components which I would normally look into. The first component is the leukocytosis, in which after a peroxidase staining, we would know for sure whether leukocytes are there or not first. Second, the organisms normally in semen are either gram-negative, like E. coli, Pseudomonas at times, Klebsiella, or they are going to be ureaplasma, mycoplasma, or they could be something like chlamydia. Now, in a culture, what normally we would get is the E. coli, the Klebsiella, but in culture, you normally do not get the chlamydia and the mycoplasma, for which you would need a PCR. So the most important thing is to examine the patient. On examination of the patient and doing a PR of this patient who has a leukocytosis, you would be able to judge whether the man has urethritis, epididymitis, or the man has prostatitis. Now it is important because the length of the therapy is going to be determined by your examination. Now, if the man has urethritis, you would probably need an antibiotic for about 2 weeks. If the man has an epididymitis, at least for 3 to 4 weeks. And if it is prostatitis, which you would know by the tenderness of the prostate, by some blood in the sample, which could be hematospermia, or you could also know it from the fact that he would probably say a painful ejaculation. Now, in these men, you need to give antibiotics from 6 weeks to up to 3 months. This becomes the dictum for it. Now, the second thing is what antibiotics to be given. So these antibiotics, which could get concentrated in the prostate and the seminal vesicles, normally are very few. It's very interesting, but they are very few. And because of the barrier which exists between the blood and the testicular, I would say the seminal barrier, antibiotics don't cross. So the antibiotics which cross this barrier comfortably are quinolones. It could be ciprofloxacin, it could be levofloxacin, and moxifloxacin 2 concentrates very beautifully in the this area. One. You also need to add something like azithromycin and doxycycline in case you suspect something like chlamydia or mycoplasma. Among the quinolones, apart from quinolones, in case the person these, I would say things like cefuroxime and these antibiotics do not concentrate much. So the basic dictum remains for us is the quinolones. And the dose has to be appropriate. Normally, these patients need the appropriate dose for a longer time. So this is what I probably would like to put in over here.
Thank you. Thank you. Amey, you're muted. Please unmute yourself.
Let's go on to specific investigations. And my question goes to Ashwini. Ashwini, which are the hormones that you would generally evaluate and how do they help in diagnosis? And we've already talked about the anti-sperm antibodies. Do you think that they are of routine importance in evaluation of a male? So first you can take the hormone question and then you could talk about the antibodies.
All right. See, as far as hormonal evaluation is there, it is only done for specific cases. They are not to be done routinely. The hormonal evaluation is generally of importance when you have cases of azoospermia, wherein you check for their FSH, and you check for their testosterone levels. And as far as your anti-sperm antibody is concerned, when you see a lot of agglutination in the semen sample, maybe that is the time that you would want to go for this anti-sperm antibody. And when the couple has infertility, then only it is significant. Otherwise, these tests are not to be done routinely.
Okay. Fine. Yeah, Amogh.
Regards to hormone evaluation, we can also do a inhibin B level. Now, inhibin B would act as a non-invasive testicular biopsy, telling us whether there is actual spermatogenesis occurring or not. So, inhibin B would be something which would help in diagnosing azoospermia if it is an obstructive or a non-obstructive one.
Yeah. So, just like hormonal evaluation is an essential part of evaluation of amenorrhea-related infertility, similarly, hormonal evaluation is also an essential part in male evaluation, especially when we are using these hormones as markers for something beyond that, something more systemic, something more endocrinological with respect to testicular failure, testicular agenesis, etc., or ruling out obstruction, non-obstruction. Move on to Kundan. Kundan, this whole myth about varicoceles and male infertility. Are we overdoing it? Are we using it as a blame game to pinpoint some excuse for infertility? What's your personal take on this?
I think as Dr. Jindal has already mentioned that clinical examination is the best way of examining or evaluating the male infertility. But I will say, yes, I do agree with his statement, but sometimes to grade the varicocele, we need ultrasound and color Doppler help to diagnose specific certain things. Now, as for example, we were discussing about varicocele. Now, as we have the literature evidence that if we have a say grade 1 that is mild to moderate varicocele, probably literature has not supported surgical advantages for varicocele surgery, and that is why these kind of grading will be possible with the help of color Doppler. And for example, say grade 3 varicocele will have a fantastic results if you do a varicocele ligation. So kind of it is very helpful to grade the disease and assess the prognosis and guide the patient accordingly that whether it will be beneficial or not. But at the same time, we should not take this statement as a pinch of salt, so that because sometimes many times it does happen that it overdiagnose the situation and then we carried away our treatment strategies, and still we don't see much improvement into the result. So even if we have any conclusive evidence by ultrasound, please, when you counsel the husband or a couple, please tell them that we have to evaluate after the surgery. 3 months later, the analysis will only help us to know whether these kind of strategies has helped or not.
So can I add something for sonography?
Yes,
sir. I think there are two aspects. One is that doing sonography for varicocele is to grade, it's okay. But I think only on gradation, you should not advise surgery. You should advise surgery on the volume of the testes. If you have a grade 3 with a very flat testes, I don't think it's worth operating on that as against a normal size testes where you would be able to downgrade the problem. That's one. And I think a very important part of sonography is transrectal sonography, which you can do in obstructive azoospermia, where you can actually pinpoint the obstruction or even find out if there is any infective pathology maybe in the prostate or seminal vesicle. So sonography is not only for varicocele. I think a large part of transrectal sonography is for obstructive azoospermia is also important.
May I add something to this? See, in the examination of the male, the basic varicocele grading is very different from the ultrasonological grading. So a subclinical varicocele would not be even felt on a Valsalva. A grade 1 would be when it is palpable, not palpable at all, it is palpable only on a Valsalva. Grade 2 is going to be when it is palpable at rest but not visible to the eyes. And grade 3 would be when it is visible and palpable at rest. So if you have a grade 2 clinically seen and or a grade 3, and along with that, the semen parameter is not normal and fertility is an issue. I mean, there's infertility and the reports of the woman are close to normal the way it would be, then these are the candidates which we would take up for surgery. Now, a very good thing, why would you like to do an ultrasound? You would like to do an examination before because you definitely would not like to operate on a subclinical or a grade 1 varicocele. One. Number two, you would also like to grade it by the ultrasound. One. In fact, if you look at the way the literature has come from ASRM, ASRM goes in for an ultrasound in any patient for documentation. But the ISHRI says that the clinical examination is the basis of your surgery, not the ultrasound. So that way it becomes very interesting that examination needs to be done properly for that.
See, that is what I want to kind of bring in here, because see what happens majority of the time, the ultrasound grading itself is different kinds of ultrasound grading. What the person is going to grade according to what grading, we don't know, because one person will be grading it differently, the next person will be grading it differently. So ultimately the most important is your physical examination and grading, and then only think of any kind of surgeries.
Yeah, one quick question before we move on to the next important point to Jindal sir. So the important take-home message that you are saying is that if there is a subclinical varicocele, we don't operate, irrespective of the semen analysis report.
Absolutely. Absolutely.
But on the other hand, if we have a grade 3 varicocele or a grade 4 or grade 5, depending on ultrasound criteria, it is worthwhile operating on these patients because they will show improvement, however it may be, okay, after surgery.
Correct.
Yeah. So I think these are two important things that we must this thing. And
I think it is also important about the testicular volume.
Yeah.
We should not just operate based on varicocele.
Yeah, because the sequelae of the varicocele will get reflected in testicular volume over a period of time. Okay, over to you, Parsu.
Yeah, I think Keshav did speak about the DNA fragmentation, the indications of DNA fragmentation on, but very quickly, what do you prefer test when you're doing in your lab, or whatever centers that you're visiting? What do you prefer test for checking DNA fragmentation?
So we, in most of the labs, we prefer sperm chromatin dispersion because it's a very easy test. You just have to stain the sample and the embryologist can read it. It takes about 1.5 to 2 hours to do, and it's correlation significant. It's you can correlate it with comet and tunnel quite significantly. But if you talk about a gold standard, then Tunnel and Comet are the gold standard test to do. But because of the lack of availability, because of the need for transport, there are so many other issues, cost factors come into play. They're not widely used. So most laboratories can easily do an SCD themselves, and that's probably why it's preferred.
And do you by any chance do seminal fluid ROS levels? Because I hear a lot of people talking about that of late.
So we don't do seminal fluid ROS. This was a test which gained a lot of significance a few years back. A lot of companies devised kits for ROS testing, but my only reason not doing it is not giving me enough evidence, because like if I do an ROS, I'm not really sure whether that ROS is affecting the sperm or not. But when I'm doing an SCD, I know that these sperms are affected, these sperms are not affected. So that was the only indication. Seminal fluid ROS, very good test to do in a research setup where they can actually distinguish between fertile men and infertile men, and also the antioxidant concentrations that are needed, etc., etc. But in a clinical setup, I don't think it has that much value.
Okay. I think Amey will be talking more about this in the coming slides in the medical management part. Before we go into the management, I think with Dr. Ameet, very basic chromosomal investigation that are needed for our male infertility patients. If it's a severe OAT or as an azoospermia, what are your basic investigations that you'll do for your patient?
So, I do 3 tests. One is a routine karyotype, so that you can pick up any Klein filters, you can pick up translocations, you can pick up Robertsonian issues. The second is I do a Y micro deletion, which cannot be picked up by normal karyotype. This is something that our gynac colleagues should understand. It's a special test which will pick up the problem on the Q arm of the Y chromosome, basically 5 and 6 region, which is the AZBG region. And the third thing I now do is fish on sperms, because this is the end organ to pick up and see if we should be having haploid sperms, but quite often you pick up sperms which are diploid, and these sperms will obviously give you aneuploidy. So these are the 3 tests. If you have somebody with bilateral absence of VAS, I think then I would want to go ahead and rule out with delta 508 to see whether there are any other genetic abnormalities.
No, cystic fibrosis, do you need to look at both couple?
Fibrosis. Now, fortunately, in our country, we can do at least 16 mutations. Previously, we didn't have the facility. So we were doing 4 and 8 mutations, which are not very common to our people, Asians, which are more common to Caucasians. But now we can do all the 16 mutations. And it may not be very freely available, but in Mumbai, we do have centers, places which do. So basically, normal karyotype and Y micro deletion, I would like to do if facilities do the sperm fish, and in specific patients, rule out cystic fibrosis.
Okay. Another issue, like whenever we have a patient like this who come for with like say azoospermia, how important, or are we in a stage, Dr. Sunil, are we in a stage today that we do a diagnostic biopsy, in the sense that is there a role for doing a histopathological examination of the testicular biopsy sample?
Yeah, this is a fantastic question. Now the issue is we would always like to do a biopsy at a place that in case sperms are present, we should be in a position to freeze them. That's the basis of a biopsy today. The second thing is, in case a patient comes to us with a biopsy, then the reading of the biopsy could prognosticate the sperm retrieval. And we would be in a position to tell them what exactly and what could be the retrieval. Like, for example, in all of them, in a hypospermatogenesis, we could get sperms in up to 70% of people. While in a Sertoli-only syndrome or a retrophic testes, the chances of getting them are very less. So therefore, you could prognosticate the patient that in hypospermatogenesis, the retrieval is going to give you good sperms in most of the people. In maturation arrest, you could get sperms up to say 40 to 50%. But in Sertoli only, please do not expect anything more or anything great. So a prognostication could be done. But yes, a biopsy prognosticates it. And what I normally do, I'll be very honest with you, I always send a sample of the patient after a TSA or a micro TSA for histopathology. And I always get it done and document it. And that becomes very important and very useful.
So why I basically asked you this question is, see what happens in a normal testis where we have not a normal testis, a testis which has got very little places of sperm production. You do a biopsy, you miss that space of where there is sperm production. And that area, what do you say? See, it is only depictive of the area of the biopsy, unlike other organs. Unfortunately, when you're doing a biopsy in the testis, so you only depict. So that is why in a lot of scenario, when we end up getting patients with, what do you say, when you're ending up getting patients with azoospermia and kind of having a Sertoli syndrome, you end up doing a biopsy, you'll end up getting sperm. Because taking it from multiple sites, ultimately, and seeing sperm is our main view, rather than actually kind of trying to do a biopsy and histopathological examination and seeing that, okay, probably this is a possibility.
Absolutely. What you're saying is the correct thing. But what I'm bringing out over here, I probably would not do a biopsy unless and until I'm taking up the patient to see if sperms are there for being frozen. But if the patient comes to me with a biopsy, I can prognosticate the patient and tell them these are the chances that we would be able to get sperms from you. This is the advantage of a biopsy.
So you would not want to do a biopsy for her. That is what
I would not do a biopsy now.
Yes, Keshav, you want to add something here?
So just adding, Dr. Jindal mentioned it briefly, but from a medical legal standpoint also, it's important that you document it, because this patient should not come back to you from another laboratory and say that, okay, they could find sperms there. So like Dr. Jindal mentioned, we also always send whatever tissue we get, a part of it always goes to histopathology, so that in the future, if there are any issues occurring, we are medical legally safe from the judgment that we've made.
I think I also want to add that 2% of azoospermic men will have carcinoma in situ. And that is something I think you can pick up when you send it for histopathology. And I think we should not miss this golden opportunity, because these are men with microlithiasis who need to be followed up even after they've had their children. I think this is something extremely important, that like PCO patients, you don't leave them after they've had children. I think these patients need to be followed up. So I would tell, the message from me is that if a biopsy is done, it has to be done in a center where the sample can be cryopreserved. I don't think you should be doing a biopsy somewhere. I think that should be discouraged, because there's no point poking the patient twice. And I think if you send it for histopathology, tell the histopathologist you want to rule out carcinoma in situ.
Okay, so now we move on to unexplained oligoasthenoteratozoospermia. I'd like to start the discussion by asking Priya. Priya, what is this syndrome and what is its clinical significance, and do you see it commonly in your practice today?
Yeah, so I was just looking at this, and these my girls just gave me the numbers. It was over a period of 2 years or 3 years, close to almost 100 cases. So you're asking unexplained, so which means we've probably ruled out causative factors right from clinical history and physical exam. Of course, we all have discussed when you would do karyotyping and Y chromosome microdeletions. So besides azoospermia, a severe OAT is also one of the indications for me where I would indulge in genetic testing. And besides that, role of medical management when you have teratozoospermia, quite unlikely. But if I were to manage such a case, I would do my investigations as I have outlined. I would put them on medical management for whatever benefits it can entail. And I wouldn't wait very long. If it's a case based on number of, if their previous history suggested that they've failed outside or they've been evaluated extensively, or, if there's a role for IUI, I would say not. I would possibly, push them towards an ART program based on their previous history and whatever I have learned from their experiences. So And oats is something where I would move towards an ART program rather than sit with IUI. And with reference to the DNA fragmentation question, I just wanted to say that between SCD and SCSA, we do SCSA at our center, and it helps a lot with us even for counseling and also managing patients where, because even in normal 7 parameters, you could have DNA fragmentation happening. So these are my way of investigation in that order for an oat person. And like I said, I would push them towards an ART program.
My question to Jatin sir. Jatin sir, in your practice over so many years, what do you think is the probable cause for an unexplained oat? Is it because of lifestyle? Is it because of elderly age or what, etc.? Are these proponents usually just hypotheses, or do you see them more often in your practice?
So almost 70 to 80%, I think, are absolutely unexplained. Until recently, we now have studies to show that most of them are cases of oxidative stress, or as we call them, medical oxidative stress infertility, which is I think the basic crux of today's discussion. So a very huge number, in fact, Ashok Agarwal published a very large paper showing that 50% of couples there is male infertility. Of those 50% male infertility, 50% have detectable causes, 50% have undetectable causes. Even in the detectable causes, 30% are MOSI, and in the undetectable, where absolutely what you asked me, unexplained oats, 80% are MOSI. And then he published another paper where he showed 90% are MOSI. So they actually do the ORP test, and then they analyzed, how these antioxidants and all these things work for these patients. So it's a huge chunk, because even if you do your varicocele studies, hormone estimations, examination by the andrologist, finally it all boils down to this oxidative stress, which is now gaining more and more importance. And that is why we need to focus a lot on this, exactly which antioxidant is the best, and not just give them a potpourri or a mixture of everything. We need to know that how to give a targeted antioxidant so that you get the best outcome.
Okay.
Can I just put something here? I think Mohan Kamath has just published a paper last week, which actually says that although there is oxidative stress, giving antioxidants that doesn't change the success rates.
So we are coming to that. Okay, just in a few slides. So to summarize, what Dr. Jatin said is that as far as oxidative stress is concerned, it could be a multifactorial problem, but the sequelae is that there is spermatozoal dysfunction, and it may be severe enough for it to cause infertility, and therefore in unexplained oat, there may be a rationale to evaluate for oxidative stress when you've ruled out everything else. Moving on to DNA fragmentation, and Dr. Patki did talk about this, is that there are various mechanisms. Some of them we still don't know, but what we know with certainty is that the damage to the DNA is secondary to the apoptosis, the abortive apoptosis process. There is an alteration in sperm maturation, and there is oxidative stress as well, caused by the excessive production of the ROS. So sperm DNA fragmentation is one of the sequelae of this entire cascade of ROS, and which is clinically significant, because once the sperms reach that stage, it becomes difficult and challenging for the infertility specialist to start treating the male factor. Now, coming on to which antioxidant is the best. I'm putting a big menu in front of you. It's a 3-course menu. Choose your pick, starting from glutathione to vitamin E, C, carnitine, coenzyme Q, N, acetylcysteine, selenium, zinc, folic acid, lycopene. It's like the therapy for COVID. Have your pick. Okay. But I'd like to ask 3 people. First, we'll start with Sunil Jindal ji. Parsu, can we go back to the previous slide? Sir, amongst this, which is your favorite drink?
See, I always give my patients vitamin C, vitamin E, and zinc with selenium. I always give them this. And on top of this, I may add anything. I may add carnitine, coenzyme Q if the motility is down, astaxanthin if the capacitation I feel is poor. But these vitamin E, vitamin C, zinc, and selenium, and they're very cheap. And the dose is such. I mean, even today, after I read the major study of all these studies on antioxidants and anti-aging, I have started taking for the last 2 years vitamin C and vitamin E. So, I mean, one is fat soluble and the other is water soluble. So I think it's very important. I mean, my choice is vitamin E, C, and then I would add what I need to add over that.
Okay. So that was the Rajasthani cuisine. Let's move on to Central India. And Amogh, what's your pick in this menu?
Yeah, I do agree with Jindal sir. My pick would be vitamin C, E. Along with that, I also add CoQ10, around 300 milligrams BD, along with folic acid and vitamin D3.
So there is the Nagpur Barfi, the orange Barfi that is coming in with the vitamin C. And now we move down south. Priya, what's your pick in all these flavors?
Okay, so I'm guilty of coenzyme Q10, like Dr. Amogh said. And also I'm a huge fan of vitamin C. And for some reason, I like calcium, vitamin D, magnesium, and zinc combination. I think that would do, because vitamin E, I'm not using much, I have to be honest. So these are my favorites from this.
Okay. So the moral of the story is pick whatever you want to, as long as it's causing no harm and as long as it's doing good for the patient. All of them have proposed roles. Probably they lead to an environment which helps in better sperm production, lesser destruction, lesser reactive oxygen species, and overall improvement in the metabolic functioning at the cellular level of sperms. Okay, we move on to the next slide. Now the question goes to Ramesh ji. Ramesh ji, as we know, is the CEO of the Ambrosia Nutraceuticals company, which has come up with this unique product. My question to you is, so what is so unique about this unique QHR in today's world?
Hello. Yeah. First of all, I like to thank Dr. Neharika to give me a chance to speak in front of such a esteemed panelist and audience. I'm not a doctor, but I'm a chemical engineer, and I was fortunate enough to get a chance to develop this product. I had an employee in China who used to work in a company manufacturing ubiquinol. He approached me saying, "Will you like to market in this India?" Now, during my chemical engineering career, I had used a lot of antioxidants, so I had some understanding. You know, ubiquinol, it increases mitochondrial energy, and it is also the strongest lipid-based antioxidant. Your body has free radicals in both lipid as well as aqueous. So I did a bit of study, found resveratrol to be most synergistic with ubiquinol. And we had developed this product for anti-aging, neuro, cardio. But because some of the IVF doctors were also using our other products, so we went to them. So one day, one of my salesperson, he met Dr. Jatin Shah. So Dr. Jatin Shah very enthusiastically asked, "Oh, this looks like a good combination." And he was not sure. So he gave him, and then after a few months, he said, "Okay, देखो तुम्हारा product ने क्या किया?" That fellow got worried कि कुछ problem हुआ होगा. So he said this fellow had almost negligible sperm count, and within 3 months, it increased to some 2.8. So basically, the thing is, ubiquinol increases mitochondrial energy, but whereas other antioxidants, they don't increase. So they are only antioxidant. Ubiquinol is both increases mitochondrial energy as well as the strongest lipid-based antioxidant. So that's why the ubiquinol plus resveratrol is the ideal combination.
Okay. So to summarize what Ramesh ji has said, this unique product, like we all know, our body needs both water soluble as well as fat soluble antioxidants. On one side, we have resveratrol, which is one of the best water based antioxidant, and on the other side, we have ubiquinol, which is one of the strongest lipid based antioxidant. And so when we have both these, there is a synergy. We are attacking both the lipid based antioxidation as well as the water based antioxidation. And therefore, can we have the next slide, please, Parsu? So it's the more bioavailable form of CoQ, and its primary role, like Ramesh ji said, is in the energy synthesis as ATP, and it is synthesized in the body, providing an active defense against against oxidative damage to lipids, proteins, and DNA. Resveratrol, as you may know, is extracted from black grapes and is one of the best water soluble antioxidants. So there is a natural basis to these preparations. They are available in nature and they have been found to be useful, not just in male infertility, but even age-related or disease-related damage which has occurred because of a various number of systemic conditions as severe as neurodegeneration, cardiac damage, renal damage, etc. Moving on to the next slide. So how does FOGSI exactly act? FOGSI is concentrated in the mitochondria, is responsible for energy movement. You know, sperm function is an energy dependent process, and reduction in levels of FOGSI in sperm cells has been shown to have be present in men who were evaluated with varicocele or with idiopathic diseases, etc. And this particular study, which is the latest study, it is as lately published as June 2020, and this looked at 65 infertile patients with idiopathic OA, and they used the WHO guidelines, and these patients were given this particular combination of FOGSI, and they found that there was a significant improvement after 3 months of therapy in concentration, motility, and also a reduction in the ROS levels. And they said that this supplementation for 3 months could improve sperm semen parameters. I'd first ask Dr. Sunil, sir, do you see any sense in this particular study? Dr. Sunil.
In fact, there are studies with coenzyme Q, there are studies with ubiquinol, and they are, in fact, they all improve stress, I mean, semen parameters, oxidative stress markers, and DNA fragmentation. There is no doubt about it. Coenzyme Q as well as ubiquinol are very highly used, but the question is that they can be combined, but that's my personal view. I mean, it's open to everybody. They should be given, but we should not, it should not happen that we do not give these patients the other options which are there, vitamin C, vitamin E.
So you would use these as well as the other options that are available.
That is what
yeah, my question goes to, can we move to Keshav first? Keshav, do you actually see in your study, which you carried out, using these various antioxidants at the lab level an improvement in semen quality?
Yeah, so I've already shown the data from our laboratory. That's from almost 200 patients where we had one control group which received nothing, and then the other group which actually got ubiquinol and resveratrol. And there was an increase in sperm counts. There was a significant increase in sperm motility, and also a significant increase in the sperm morphology. So that's one thing which really actually I have now changed towards ubiquinol and resveratrol instead of using any of the other, because it's showing good significance within 3 months of therapy.
Okay. My next question goes
to...
Can
I just ask, can I just butt in here? Yes. I think all male infertility studies basically are flawed because the primary endpoint should be pregnancy, like you have in female infertility.
Yeah.
When you have improvement of semen characteristics, that doesn't help my patient. He's not come to improve his sperm motility. He's come to have a baby. So I think, that is the biggest problem. I'm not against any study, but all studies, I think a primary endpoint has to be pregnancy, like we have for female factors. If you have any drug, clomiphene, letrozole, gonadotropins, we take primary endpoint as pregnancy. I think we should be doing that. Only then I think we will get some fruitful knowledge out of the various studies that are done.
And that's why I mentioned these as preliminary results, because...
Yeah. No, I'm not talking in your study. I'm saying all studies in male infertility.
That's true, sir.
The primary endpoint should be shifted.
That's a good take-home message for Ramesh ji. Maybe he should now start his next trials keeping that particular endpoint. My quick question to Jatin sir, so do you recommend these antioxidants in patients who are preparing for an IVF?
Yeah, we normally do, but like Ameet correctly said, the whole thing is now, how do you know that the pregnancy was because of the antioxidant or because of the ICSI? So, the best way is only if you give, 100 patients in both arms the antioxidants, then wait for 6 months for spontaneous pregnancy, which, in today's world, I doubt any ART clinic would do. Although
you
it is
need
the
not
ideal
wait
way
for-
to do it, but it's very difficult to do it. And
You
in
need
ART,
not wait
that's why I
for
keep telling
natural
Ramesh also that, I can't really say that the pregnancy is because of this, but since there is no harm in giving it, we like to give it.
Maybe we can add in patients that go in for IVF who have undergone treatment for with antioxidants. You can add your KPI markers as day 3 embryo, or how is the morphology of day 3, what is your blastocyst formation rate, what is your implantation rate, what is the implantation failure rate, and subsequently what is the pregnancy rate and the time to pregnancy. So when we incorporate all these factors in any study, that will actually give us whether an antioxidant, particular antioxidant, is working or not. So as mentioned,
Amogh has nailed it well. We don't have to wait for natural pregnancies, but in ICSI pregnancies itself, we can see whether it is affecting the embryo quality.
I think that would be a very comprehensive and correct study, starting from evaluation of the semen parameters, the embryo quality, the implantation rates, and finally the take-home baby rate. That would give us a complete picture about its, undoubted utility if we are able to prove it.
One more point, if I can add.
Can I say something?
Yeah.
Most doctors who are using, like Dr. Jatin and most have the feedback. What we have got is they find better embryo quality once they use ubiquinol and resveratrol. So this is the feedback we have got from doctors. The embryo quality definitely improves.
I just
to be documented.
Yeah, we need to document it. We need to publish it.
I think we have a little short of time. I think we'll just go.
Also, you move on.
Yeah, Ameet sir, quick answers. Where would you use clomiphene citrate in male infertility?
Clomiphene citrate only in patients where the FSH is low.
There is no a normal FSH or
the male factor with the FSH is low.
Letrozole?
Letrozole similarly, whether
basically you're talking about these obese patients who are having high estrogen levels, estrogen levels, only in that group of patients. A lot of people actually end up giving clomiphene citrate and letrozole in for a lot of these 25 milligram clomiphene citrate is given up and down. So you don't recommend for all patients of OAT to be given clomiphene citrate.
No. In fact, you will worsen their case if you give it in the wrong patients.
Correct.
Gonadotropins again only in hypo patients, explaining to them that it may be months that you may have to give it, and it is not only for 20 days or 30 days.
Correct.
I've got sometimes you have to go to 90 days.
I think Parsu, we've lost him again.
Yeah. Okay.
It is perfectly where the FSH is low and where the testosterone is low or low normal.
Yeah.
These are the conditions where I'd give clomiphene. I'll get a testosterone estrogen done. If the ratio is reversed or around 10, then I'm going to give aromatase inhibitors to these, letrozole or anastrozole.
So basically the whole idea is, again, FSH value, how important FSH value is. Actually, a lot of people always ask me, what is the role of FSH in male infertility? I think as much as how much in value FSH has in female infertility, FSH has a value in male infertility also.
And testosterone. And testosterone.
Obviously, yes. I think varicocele we did talk about. I think NM sir is still with us, or okay, because this is a very generalized question, or else Ashwini and Ashwini can come in here and tell me, like, IUI means, see, which group of patients do you think an IUI can be done up to what 7 parameters? If you want to do an IUI, what is your preferred 7 processing technique? And more importantly, whom we should not do an IUI?
Okay. See, as far as IUI is concerned, it should be taken as the first line of treatment when a patient comes to you rather than directly jumping for IVF. I would go in for the total motile sperm count. It should at least be 5 million in a native sample when I'm going for an IUI. And as far as semen processing technique is concerned, if it is a sample of OATS, then I would go in for the the density gradient. And the other cases, a swim up technique would be enough. And whom not to do an IUI when the couple is serodiscordant, if there's bilateral tubal blockage, or if it is a very severe case of OATS, or if you have retrieved the sample by a TESE or a microsurgical extraction, all these cases you would have to do an IVF or an ICSI.
Okay. Amogh, do you want to add something here?
I think the total, instead of taking the total motile count, I would consider the sperm concentration in these patients. If there is teratozospermia with a count or concentration of 10 million, such patients will not have a good pregnancy, and they are liable to have early pregnancy losses. Secondly, in case of semen preparation techniques, I agree with Dr. Ashwini, but I would like to add one more thing. The amount and the rate of centrifugation will again cause ROS formation in the prepared semen sample. So are we all doing a DNA fragmentation post-wash? Maybe it may be a retrospective study, but what is the ideal centrifugation rate? Because it's a personal study that we are conducting. What we found out was the normal rate at which we centrifuge the sperm while preparing, there is increase in DNA fragmentation as compared to the semen sample that we get. So
one more thing, one quick question to you. If somebody comes to for an IUI, what is the abstinence you tell them? Don't have sex till the IUI is decided, or just tell me.
3 days before the IUI, have sex.
Why 3 days before IUI? Why can't he have sex that day morning?
This would be much better.
In fact, the second sample within 1 hour is the best.
I think the whole idea is that I think a lot of people don't understand that.
Oats. And also, in density gradient, the advantage is that there is no release of ROS because you're separating out the various components. Sperms are separated from dead cells, WBCs, pathogenic matter. So I don't know. That's what I have read a lot, that the density gradient, in fact, doesn't release ROS because you are not subjecting normal sperms, to be mixed up with all the other elements whose cell membranes disrupt, and the ROS is released. So a normal spin and swim up, yes, you're right, that harsh centrifugation, because sperms, dead sperms, everything is centrifuged together, you often have a lot of ROS release there. And just to complete this, where we take a cutoff is not the initial sperm count, but the post-wash rapidly progressive motile sperm count, with, as Amogh said correctly, at least a decent percentage of good morphology sperms. So if that is more than 1 million, then it's a perfect candidate for IUI. Less than 0.5 million rapid linear progressive motile sperm after wash is straight away an indication for ICSI usually. And between 0.5 and 1 is a gray zone where you can decide as per the age of the patient. If she's very young, maybe 1 or 2 IUIs could be done. So it has to be individualized like that.
Okay, a food for thought. Basically, that I think we have come talking about so much of centrifugation causing sperm damage. Are we going to an era of intravaginal insemination of just the seminal fluid, especially in patients with sexual problems? No more IUI, not intrauterine, just a fresh semen sample, just put them into the vagina. I think a lot of people are doing it. I think are we going back there? And
No, but we are moving towards using more unconventional approaches like microfluidics, etc., where centrifugation can be avoided. So that might be.
Then to you, what are your direct indications for IV FOGSI, Keshav?
Direct indication, Jatin, Dr. Jatin just mentioned, if severe low counts, severe teratozospermia, even asthenospermia, I would advise ICSI. In cases where there's a high DNA fragmentation, I would go in for sperm selection and ICSI.
That I'll leave it to Priya.
Yeah. Okay. Also, if it's a testicular sample, ICSI has to be done.
All right. So Priya, what is your preferred sperm selection technique? Do you want to do it in the first cycle of IVF, or you want them to fail once and then do it in the second cycle?
I mean, sperm selection. Okay, first of all, largely I agree with all the points raised by Keshav. Second is we do almost 90% ICSI. So, and sperm selection method, it's based on the count and motility and morphology. So quickly to tell you, I'm a huge fan of the double density gradient separation. And beyond that, there is a place for microfluidics in our lab. So we do these two methods a lot. And then there is FOGSI and IMSI for very specific indications. IMSI is completely last on the list. So this is, if I have put the case through an ICSI cycle, then this will be the order of sperm selection methods that I would stick to.
Perfect.
Yeah, so the days of IVF are coming to an end.
So I am very sorry to tell you, I have to be frank, but we are quite skeptical. Even if the counts are normal, we don't see the kind of motility that we want to see. So, and we get all referral cases, we've become a referral lab. So it just makes more sense for us to stick to ICSI And when we have the protocols in place and we're comfortable with it, I give very little place for IVF, maybe in OHSS and where we can afford to, or immature, when we're picking up the eggs and you see that it is not really fully mature and things. So then we just inseminate and leave. And recently we did well in IVF for 2 or 3 cases this past 2 weeks where there was good fertilization. So I'm not ruling it out, but I have to really think about my, success of fertilization happening with what's given to me in the lab. So.
Ashwini, specific indications for donor insemination?
Serodiscordant couples, atrophic testis, and if there's no chance of retrieving the sperms even after you've tried out everything.
Severe OAT, somebody who's not affordable?
Okay, you can try that. Maybe do a low-cost ICSI for that couple.
High DNA fragmentation, which is not getting corrected. I think I heard a lot of people talk about that also. Is it something that is accepted?
I don't think so. I mean, you just have to see for the cause for the high DFI. At times it happens that if the cause is post-testicular, it gets easily corrected. And maybe you also have to check for which method you're following, if it's the same method when you're repeating it.
Dr. Ameet, again, coming back to you.
For donor sperms in serodiscordant couples?
Yeah.
I don't agree with that.
I mean, if it is a, what do you say? If
the
it's
husband is positive.
The husband is positive.
So how does it matter? There are a lot of studies. You can do a gradient wash and do an IUI and the transmission is zero.
Majority of the time it is done.
You treat them with
almost
0%.
0%.
Get their loads of almost zero,
viral load,
exactly. Sperm wash, and I think you can be quite sure you will not pass on the infection.
So the CD4 count and the error load decides and helps you to decide whether own sperm should be used or no. So two things, if they're well controlled, you can safely go ahead with IUI.
The largest study which they're saying that they have done an IUI for patients with low CD4 count and this and that. They've not been proven. There's not a single case that has been proven to have transmitted HIV in that. But the theoretical possibility is that is one of the options that a lot of people give, comes in on the list of indications of IUI. But yes, it is a decision of the patient. I wouldn't say that it is something that is a 100% indication, but then that again is a decision of the patient.
There is a very nice statement, ethical statement by ISAR, which came in Dr. Durusha's ear on HIV and serodiscordant couples. I think I would request all the audience to go through that. It's free to available on GHRS.
Okay, and Dr. Ameet, a very common thing, a lot of people talk about this today, testless sperm in patients with high DNA fragmentation. The patient is actually ejaculating sperm, but then you go back to the testis and take the sperm out and use it for ICSI and IVF. Do you believe in it, and do you think there's a logic in it?
Yes, I have done it in some of the patients who have failed before, and now I keep my options open when patients have got very high DNA fragmentation, because that is one way that you can actually reduce the DNA fragmentation by taking sperms directly from the testes. So in severe OAT, I counsel the patient and I tell them, because this is one group where you cannot do the DNA fragmentation also if you have got very severe OAT. So in such patients, even if I see sperms, I would counsel the patient and tell them that I would want to go for a testicular sample.
But Keshav, please add.
Yeah, so I was not a proponent of it till I saw the studies and the evidences behind it, and this really works. There is huge data from India from Dr. Deendayal's group, 8,000 plus patients where they've done testicular sperm compared to other sperm selection modalities, found it to be much better. So I think it really works for these patients.
And Centro Estevas has published trial papers in 14, 16, 18 and 19 on the same subject. And he's shown every time significantly higher pregnancy rates with testicular sperm. The argument was that with testicular sperm, maybe you have higher aneuploidy rates, but even to set that at rest, there is a recent publication that it depends on how you tested the aneuploidies. And in fact, there are more aneuploidies with ejaculated sperm in high DFI as compared to testicular sperm. So now I think there's, like Ameet clearly said, we have enough data that there is a definite advantage in doing testicular.
In all these patients, I'll just add something. In all these patients in whom all these Centro STVs, of course, along with Dr. Deendayal's these papers, in all those patients who have tried ICSI before and have not got pregnant, there is an OAT, and in these patients, testicular sperm becomes something which you need to think about.
Yes.
See, I think we have to add this previous IVF failure into the indication for testicular sperm extraction, addition to high sperm DFI. So I think it's not that all the patient who's got a high DFI, we should subject straight away for testicular.
That is what I
We
want
have to have a history of
only
it's very important.
We've already discussed this, but quickly to just prove that you can look at the volume of the testes first and do an FSH level. These two should be your cardinal screening methods to understand whether it's a hypogonadotrophic, obstructive or non-obstructive type of azoospermia, as well as the size of the testes. So in doubtful diagnosis, we've already discussed testicular biopsy is important. We'll move on to the next type of dysfunction, and we'll have a quick opinion from Kundan. Kundan, performance. Okay, so what's your way of treating performance-related problems, ejaculatory dysfunction and erectile dysfunction? We'll start with ejaculation.
Okay, I think it's, the unejaculation is specifically related to the orgasm failure, and I think it's more related to the nervous system rather than any kind of vascular system. So typically in unejaculation patients, electrical stimulation does help. Sometimes even if it is there is no response to a couple of attempts of electrical stimulation, then I think straight away we can directly go for PISA aspiration, that is PISA, and do the ICSI with those pumps. So I think unejaculation is typically also can be related to the hormonal issues, especially the hyperprolactinemia, and the certain drugs like antihypertensive drugs, they do affect the unejaculation. And the second thing which you said about erectile dysfunction.
Premature ejaculation.
Right?
Premature ejaculation.
I think premature ejaculation should not be considered as a problem. It is considered as a situation. So I think there are some medical drugs. I think I don't remember the name, but I think that is something which is useful. But the evidence says that it is not a problem, or it doesn't cause as a infertility. Okay, so I don't consider this as a problem.
And erectile dysfunction?
Yes, erectile dysfunction, again, hyperprolactinemia is very common. Certain drugs like, as I said, antihypertensive drugs, and diabetes is very, very common cause for erectile dysfunction. If we have ruled out these three functions, then these three problems, then comes a medical therapy where typically for such patient, vasodilator drugs like sildenafil will be used as a challenged therapy. If the patient has a good erection with the sildenafil and having a good ejaculation, then that actually solves their problem, because they can use that drug intermittently, especially during the fertile period. But suppose even if after the drug therapy, even if there is erectile dysfunction, then straight away it's better to go for PISA and ICSI.
What about retrograde ejaculation? Urologist problem or andrologist problem or gynecologist problem?
I don't think so. It's limited to one particular profession related problem. But I think the simple thing is that we have to extract the sperms. So you have to process the post ejaculated urine properly, and we can safely have a good number of sperms for ICSI. But of course, it's not suggested that we should utilize it for the IUI, because the results are little poor. So I think just selection process is very important. Isolation of the sperms process is very important from the urine. And after that, you submit them for the ICSI. I think that is the best way.
Alkalinization of the urine is important for at least 3 days prior to collecting the sample.
And also there is a good option of electroejaculation in anejaculation, which works well. So it's non-invasive compared to directly going for a TISA.
We did say, sir, about electroejaculation as the first line.
In fact,
so can we go to the next slide, because we are running short of time?
Yeah, Dr. Jatin, like I said, we did talk about, so nowadays if your patient comes to you with a obstructive azoospermia, you would prefer to do a PISA itself, or you want to do a TISA? But because now a lot of these studies are coming that saying that, okay, yes, probably this is an accumulated sperm that has been stuck there and you want to take it from the testis, or you prefer from the
if you have an experienced andrologist, like we have Dr. Rupin Chow comes to a place, he always prefers to do a PISA, at least one PISA, or sometimes even two. And he maybe has a technique of going to the distal part where he gets probably the fresher sperm than all the dead sperms. But like you correctly said, it's no point going on and on. If you don't get it in one or maybe maximum 2 shots, it's always quicker to do a TISA for these patients.
So where is the indication where you decide the patient whether you want to divide it between a TISA and a micro TISA? because there are these lot of these, because a lot of us are not blessed with the opportunity to have a in-house urologist who is equipped to do a micro TISA. So at that point of time, is it important that every patient should have had a TISA, trial TISA before and then only decided for micro TISA, or already with high FSH levels, you directly take them for micro TISA?
No, so we don't believe in trial TISAs or anything like that. TISA is always done on the day of egg retrieval for most ICSI patients, because usually the endocrinologist will be able to prognosticate to the patient, okay, there's a 30% chance, 50% chance, 70% chance, and there's no point in doing trial biopsies. Like we heard earlier, you may do a biopsy from an area which doesn't have spermatogenesis, and just about 20 microns away, there may be an area which does have spermatogenesis. So best is obviously TISA is much more cost effective. You will find sperm in 80 to 90% of cases, and that leaves you only with the very difficult cases, in very small testicular volume, high FSH, previous multiple attempts where no sperms have been found. Those cases you can primarily post for micro TISA, because micro TISA has its own pitfalls and disadvantages. So TISA is always preferred, and normally what Rupin likes to do is 3 to 6 biopsies from both the testicles, and 8 out of 10 you usually would find sperm in, if they are good cases. Like we heard before, and just to recap, 25% of cases, not very low, of Sertoli cell only syndrome, 35% of maturation arrest, and 90% whose testicular biopsy report in the past has shown severe hypospermatogenesis will give you good sperm at TISA. So don't, just on one biopsy report, you cannot tell the patient, oh, you are not going to have sperm and go for a micro TISA. So these important statistics are important when you counsel a patient. What are the chances? And I would definitely prefer straightforward TISA, which is less invasive, cost effective, compared to the cost of a micro TISA. It's really, really cost effective. No, but and your probability of finding sperm is very high.
So do you want to do the micro TISA previous day? If the patient you're posting for a micro TISA, you want to do it the previous day or on the same day? Only when you have a failed TISA?
Do it on the previous day, because if you have to do justice to micro TISA, you need a laboratory which is well equipped to study those samples. If you look at all the studies of micro TISA, the best results are if the search time is 4 to 8 hours. And there are not 1 but 4 embryologists searching each and every shred of seminiferous tubule that you retrieve. So you tell me how many labs in the country can really do justice to this kind of a search. So it's very important that only if you have all the infrastructure in place, can you do a good micro TISA for these patients. So counseling is important, infrastructure is important, patience of the embryologist is important, and the will that I will find sperm in this case. So all these things contribute a lot to micro TISA.
May I add a comment to this? Interesting, Dr. Jatin. I mean, you've summarized everything so fast. But in any patient, the first thing which I probably would like to do is to judge whether the patient has what kind of azoospermia. He has obstructive azoospermia or non-obstructive azoospermia. So one thing is very clear, that you would do a PISA only in an obstructive azoospermia. You probably would do a TISA. I'm not talking of a TISA. I'm talking of a TISA only in an obstructive azoospermia, not in a non-obstructive azoospermia. And why do they say that don't do a PISA and do a TISA? Basically is that once you put in a needle into the epididymis, in case there was a chance of this person developing sperms or making sperms later on, is finished for life, because the epididymis would get broken and sperms will not pass through it. So supposing there is a patient who has varicocele, I'm just giving you an example. There are a lot of studies in patients with varicocele, in whom post-varicocele surgery, you have been able to get sperms in the ejaculate. Now, there could be patients in whom you do not want to touch the epididymis, or the epididymis on palpation is flaccid, not very full. These are the patients where you would probably like to do a TISA or a failed PISA in an obstructive azoospermia. But in non-obstructive azoospermia, in case the report which you have got earlier, the testicular size is less, if you have a report of maturation arrest or Sertoli only, then micro TISA is the answer for that. But in case you have a report of hypospermatogenesis, you definitely can go ahead and do a TISA or a multiple biopsy TISA in these patients.
Okay. Parsu, can we move on?
Yeah.
So we'd like a quick shairana andaz from Sunil sir. Sunil sir, ek shairi ho jaye, which will set the tone for the conclusion of this panel about male infertility.
I was just thinking one day, I just listened recently to a mushaira in which there was Kumar Vishwas speaking. And he said, इतना खूबसूरत शेर बोला उन्होंने, मतलब आप सुनेंगे तो मुझे ऐसा लगा कि वाकई में मेल इनफर्टिलिटी पे बोले हैं. ना पाने की खुशी है कुछ, ना पाने की खुशी है कुछ, ना खोने का ही कोई गम है। ना पाने की खुशी है कुछ, ना ही खोने का गम है। ये दौलत और शोहरत सिर्फ कुछ जख्मों का मरहम है। अजब सी कशमकश है रोज जीने में, मरने में। मुकम्मल जिंदगी है मगर पूरी से कुछ कम है। Now, ejaculated dysfunction, this is what happens. Premature ejaculation, this is what happens. Low sperm count, this is what happens. मतलब आप अगर मेरी बात माने ना, सबसे दुखी आदमी तभी होता है जब उसका sperm count कम होता है. So this is the way it is, and thank you very much for this beautiful panel which you have done. It has been amazing.
Can we move on to the last slide? Yeah, so I would like to conclude by saying on behalf of Parasuram and myself that this particular saying by Nick Lackey probably summarizes the neglected male in male factor infertility, because he aims, as this quote has said, to quote, "To me, having kids is the ultimate job in life. I want to be the most successful at being a good father." And I think just like we offer motherhood to our patients, I think fatherhood is an equally important role, and therefore the importance of the neglected male and the management of male factor of infertility. On behalf of Parshuram and myself, I'd like to thank Neharika, the organizers for today's webinar, Ambrosia NutriCare, and of course, the eminent group of panelists who made this panel such an important, interactive, and successful effort. And last but not the least, the delegates and attendees who have stood by us and listened to all the important knowledge that was disseminated by such eminent IVF specialists from across the country. Thank you all.
Thank you. Thank you so much.
Thank you very much.
Thank you.
Thank you so much.
Thank you, Amey. Thank you, Parasuram. Thank you, Amogh.
Thank you, sir.
Big thank you to Neharika, of course. Keshav.
Thanks to all the panelists.
Thank you, everybody. Thank you to everybody.
I don't think anybody has this thing to kind of take in any more questions, no, from the Q&A session.
I've tried to answer them.
Yeah, I think you have answered majority of them. So thank you to the audience.
Thank you, everyone.
Thank you, Neharika.
In the end, I would just like to say, each year, as you know, that International Men's Day is celebrated on November 19th. And the aim of this Men's Day is to celebrate positive men role models and, to bring in awareness issues in men's issues. So, that is why today was such an important day. And as Young Talent Promotion Committee, we thought we would do a panel discussion on male infertility. We know over the past 40 years, as all you have discussed, that sperm counts have come down to half and sperm quality is also now declining.